My name's Dr. Wangler. I'm a pediatrician and medical geneticist at Texas Children's Hospital in Houston, Texas. I got interested in peroxisomal disorders from a patient that I cared for sort of in the hospital as a resident, and I sort of never stopped. So my purpose today is to present some slide material to you. The purpose of the slides is to sort of give an overview of peroxisomal disorders. I hope to increase, sort of your general knowledge. I should tell you that some of these slides are at a pretty high level. I sort of took the slides that I gave to our genetic counseling students and our graduate students. I reduced the material to a point where I think you might not walk out of the room, but not by much. And that's intentional because you are as you have learned, or as you may already know, you are often the most knowledgeable person in the room about peroxisomal disorders in clinics so there are many opportunities for you to find good doctors and find knowledgeable medical professionals, but you are often the one who knows the most about peroxisomal disorders. And so the purpose is to hopefully help you on that journey. So here's what we're going to go over. So first we'll talk about what are peroxisomes, what are peroxisomal disorders, how are the disorders diagnosed by physicians and medical professionals. We're going to talk about the Zellweger spectrum and what happens on Google, and then what can I do for my loved one with a peroxisomal disorder. So, okay, so this is a picture from a liver from, just sort of a patient at Texas Children's without a peroxisomal disorder. This was taken by a pathologist, and what you can see in the middle are these kind of dense bodies inside the cell, and that is a peroxisome. So peroxisomes are basically a special organelle. So what are organelles? So in cell biology, organelles are sort of like the organs of the cell. So our body's made up of cells, and the cell actually has its own specialized compartments. And why do we need organelles? Well, organelles create a unique environment for unique things to happen. So you can't just have a cell where everything's happening willy-nilly all over the cell. You have to have unique compartments where very specialized things can occur. And the peroxisome is basically like a factory inside the cell for specific types of metabolism. So the GFPD made this helpful graphic that discusses what is a peroxisome. So if you look carefully at this picture, what you're seeing is a cell, and you can see all the different little organelles, right? The organs of the cell. And the peroxisome is sort of the little round bluish organelle. This kind of is the center of where these diseases come from. So peroxisomal biogenesis, so that's a term that you may hear. So that is, how does the cell produce those peroxisomes? How does it make those organelles? Biogenesis is the sort of going from the beginning and making the organelle. And basically this is a process that we call evolutionary conserved. So yeast, all the way up to humans, all those organisms do peroxisomal biogenesis. So that's part of why there's useful material to learn in genetic laboratories, because even a yeast cell has to do the same task that human cells do. One thing that's unique about peroxisomes is we believe they're made essentially from scratch. So there's some organelles like mitochondria that you have to have mitochondria around to make them, but we believe that we can sort of generate peroxisomes from scratch. And so then I say without this, the enzymes don't how to target. I'm going to explain a little bit more what this means, but without peroxisomal biogenesis, you actually can't get the workers to the right compartment. They can't reach the peroxisome, and that's a problem for a lot of our patients. So this is a graphic that we made for a paper, and it kind of shows, what I want you to take from it is that there are these genes called the PEX genes, and they do certain steps. There's a stepwise process where I start out with a bit of sort of membrane, like a little compartment, and then I gradually populate it with the proteins that I need to make a mature peroxisome. And so, so just sort of have in your mind that there are these genes, the PEX genes, and they help the peroxisome on its journey to being made. And then, okay, this, speaking of graduate student level stuff, but I mean, this is important because basically we take in material from our diet. We also, our cells make metabolites, our cells make lipids. And the peroxisomal beta oxidation system, this is like a key engine in our cells for metabolizing a lot of those materials. And you can see that there's many different types of metabolites that have to feed into that system. So if I'm missing that system, there are a lot of different places where a traffic jam can occur. Okay, and then one more sort of introductory level discussion is what are very long chain fatty acids. Okay, so I think we're all familiar with fatty acids, but there's a more rare subcomponent that's in all of our fats that are called very long chain fatty acids. So most of the fat you encounter from your diet is probably carbon 16, carbon 18. So here we're talking about more than 22 carbons, carbon 24, carbon 26. Those become a lot more rare in our bodies, but so they're much less abundant. They're synthesized, or we take them in our diet, but we basically need the peroxisome to handle those. So without the peroxisome, we can't handle those fats. Okay, so part of the reason for going into that level of detail is because if you think about it for a minute, you go, okay, I see. So there's a biochemical factory, and it has these enzyme components, and those enzyme components sort of have to be built. So if the builders don't show up for their jobs, then the factory isn't made, none of the workers can find their way. But then also you could have maybe particular workers that don't show up, and in that case, particular biochemicals would accumulate. So that's the two major types of our disorders. The single enzyme disorders, this is where a specific worker doesn't show up. You can see a specific problem. The biogenesis disorder, the builders didn't show up, none of the workers could reach their target, and so you can see generalized problems. And so then that's why we classify the human disorders into single enzyme and biogenesis. So the biogenesis disorders are a clinical spectrum of disease, and this is where a lot of confusion can originate, because we really want to call these, and we encourage everyone to call them peroxisomal biogenesis disorders. And many of the kids here are on the Zellweger spectrum. So I don't, I can't make it any better. This is sort of what we've decided to do, and I do think it's the best solution. I don't like that we have peroxisomal biogenesis disorder, Zellweger spectrum disorder, so we say disorders twice. We have 6 words and we say the same word twice. But this is better than what we had before, believe me, because what we had before was we were telling some families, well, you have Zellweger syndrome. And then we're telling other families, it looks like neonatal adrenoleukodystrophy. And then other families, it looks like infantile Rett syndrome. And those were older terminologies based on the similarity of the disorders to like other disorders. And what we realize is that all these are due to PEX mutations. So I think you could think of it as PEX deficiencies, but we really encourage everyone to say PBD-ZSD. And these do exist on a spectrum where we can observe patients who are very severe, all the way out to patients who have more relatively mild conditions. And there's a correlation, by the way, there's a good correlation between the biochemistry. So if the very long-chain fatty acids are very, very high consistently, that's probably a patient with more severe clinical features. And then when we find a mutation, those are probably stronger mutations that disrupt the PEX genes more strongly. In contrast, there could be subtle mutations in a PEX gene where the very long-chain fatty acids are more mild. There's even been situations where a measurement of VLCFAs could be normal, and then those patients would have milder phenotypes. So, what about the genetics? So all the PEX genes, and actually all the disorders that we're talking about except for X-linked adrenal dystrophy, are what we call autosomal recessive disorders. So in an autosomal recessive disorder, there's basically two parental carriers. They have mutations in the same gene. Not necessarily the same mutation. Each parent could carry a different mutation, but it's in the same gene. So then with each pregnancy, there's a 25% chance of having a child affected by the disorder, because each parent has a 50-50 chance to pass on the mutation, and then we sort of add up 50-50 times 50-50, 1/4. Half of the children will then go on to be carriers, so that's sort of 50% chance with each pregnancy. And then another 25% would inherit sort of 2 clean copies. So this is sort of the most common standard inheritance for these disorders. Important to keep in mind that this is like flipping coins. So you could have 4 children, all 4 could have peroxisomal disorders. You could have families out there who both parents are carriers. They never knew because they ended up with sort of only having children who were carriers or unaffected. Okay, so this is also helpful from the GFPD and sort of emphasizes what I said before, that this is the terminology that we are using now: peroxisomal biogenesis disorders, single enzyme protein deficiency disorders. So stick to the top. The bottom is the mess we used to have. It's just, but I want you to know also, because you may read something that has the historic terminology. So if you read something that has the historic terminology, the solution is go to this slide that I think Katie Sacker made, and Amy made, and sort of check out where are we on the standard terminology. Okay, so this is a study that we did, actually, starting at a GFPD meeting several years back. We're hoping to continue that study actually at this meeting. The point I want to make here is that we did human plasma metabolomics. And so what's shown here is what we call a heat map. Each column of that diagram represents an individual sample from a patient with PBD. And then each row is an analyte. So there's over 700 chemical compounds that are found in our bodies that are along the rows. The rows are so small you can't really even see individual, but you can see bands that start to form, and you can see consistent, what I would call patterns. So the patients often have issues with phosphoethanolamine and phosphatidylcholine, so phospholipids that make up the cell membranes. Plasmalogens are reduced, and then sphingolipids, that's something that we're interested in researching, are also reduced. But the point is that the biogenesis disorders give us a distinct pattern, and it hits many different pathways, which is what we predict from having all the workers couldn't show up for their job. So not all the biogenesis disorders are Zellweger spectrum disorders. So rhizomelic chondrodysplasia punctata, which we call RCDP, is a different biogenesis disorder. They have a very different phenotype from the peroxisomal Zellweger spectrum disorder. A lot of it is skeletal manifestations, and then there's a lot of brain manifestations in this condition. And this is just showing that basically the key is the proteins involved in RCDP are also, also a PEX protein, also involved in getting the workers to their job. But what I just want you to understand is that ZSD is not the only biogenesis disorder. Okay, and then I'll just briefly touch on a couple of the single enzyme disorders. So one to know about is called X-linked adrenoleukodystrophy. This is actually the most common peroxisomal disorder. This leads to a defect in very long-chain fatty acids, so those patients have elevated very long-chain fatty acids. And we're going to talk about newborn screening in a second. Then there's D bifunctional protein, which we've had several families in the GFPD. And that's actually a sort of a very severe defect in very long-chain fatty acid metabolism. And then Refsum disease, that's more of an adult condition that often involves retinal hearing loss. That's due to phytanic acid buildup. And that is also considered a single enzyme disorder. So, so the X-linked adrenoleukodystrophy, just to give you an idea, this has 3 forms. So there's children who have a childhood cerebral form. They can present between 4 and 8 years. And that is like a progressive neurodegenerative disorder. They have a leukodystrophy that some of the ZSD kids who develop leukodystrophy, there's a lot of parallels between those situations. And those kids, bone marrow transplant could halt the progression. So the reason for mentioning that is that possible therapy has led most states in the US to adopt newborn screening for this condition, because if we could find those kids early enough, there's a possibility of making a difference in stopping the progression. There's other individuals with the same mutations who can have later in life adrenomyeloneuropathy or an endocrine disorder. But the adrenal disorder is very similar between XALD and PBD. So that's another reason to sort of just know about it. So this needs to be updated, but what you can see is that newborn screening has launched in many states for ALD. So we are now screening for adrenoleukodystrophy. Actually, it would be interesting for me if, is anyone here, like a family member was picked up originally by newborn, okay, by XLD newborn screening, okay. Oh, okay, okay, well, welcome. All right, so how are the disorders diagnosed? This is another helpful graphic, but basically the other thing I want to kind of bring you in on is that we are changing our, the algorithms and the way families are coming to us is changing rapidly. So it used to be that a patient would have symptoms, be sent to some expert, like maybe a neurologist or medical geneticist, and then that person would think, oh, I wonder if this is a peroxisomal disorder, and specifically test biochemically. And then if the biochemical was abnormal, then they say, let's do some DNA testing. But now a lot of those things are being reversed, where maybe there's some symptoms early on in, say, a NICU. And sequencing is done almost immediately. Or with the newborn screen, a biochemical abnormality is found before we even know much about the baby. And so the idea is that technology is sort of outrunning us, where we're finding out about the abnormality before we even have a handle on the clinical part. We're doing the clinical part second to see, do we think this is actually happening? So that's something to just keep in mind. So, okay, so this is just trying to reiterate what I just said, which is that, that if you read the textbooks about how am I going to diagnose these disorders, it's going to say, well, you have to recognize the features. Here's a list of the features. You'll test very long-chain fatty acids. You'll do some additional testing to confirm or determine what kind of peroxisomal disorder. And then you'll think about what genes and do DNA sequencing for those genes. So that's like when I sort of started, that's what we were doing. But now what we're doing is like being called and being sent a report that has PEX mutations on it. And then sort of saying, well, where is that family and who are they and what's, or having an abnormal newborn screening. And one key, just to keep in mind, is that for peroxisomal disorder, for the biogenesis disorders in the Zellweger spectrum, the XALD newborn screen is typically going to be positive, almost universally. But then the DNA that they run is only for ALD. Because remember, the newborn screen was for ALD. So you may get back a report that says, well, the ALD was negative. But you actually have to then continue to say, okay, well, what caused a positive screen? And that is most likely a Zellweger spectrum disorder. So that's one complication that we have right now. Okay, so I'm going to end and then I want to discuss. So some practical advice that I want to give you. So one is obtain your results. Particularly DNA is helpful for me as a geneticist, but even maybe if it's biochemical results, I would encourage you to actually obtain those results. So many, many physician offices, they might call you, they might discuss the results, maybe you discuss with a genetic counselor, but I would still encourage you, you can have that report. They can send you the full report. And then you should have it. Because then it's much easier to define what you're dealing with. If you end up in an emergency room or somewhere where a doctor doesn't know what this is, actually a gene name helps a lot. A name of a condition specified on a report can help a lot in that situation. There are peroxisomal disorder treatment guidelines that we wrote as a GFPD group several years ago, and share those liberally with physicians. If a physician passes past your child on the street, share those guidelines with that physician. And then one other thing I want to bring up is the discussion of severity. So this was particularly happening to us where if the moment someone says Zellweger or Zellweger spectrum, people are Googling that, right? And then they'll pass the Renee Zellweger stuff, but then when they get to Zellweger syndrome, so if you Google Zellweger syndrome, now remember, you're probably learning about what we would call severe PBD-ZSD, but maybe you're not. Maybe your child is actually not on the severe end of the spectrum. So the information that you're getting from that can actually be very deceptive. So that's why getting your report, getting maybe the genotypes, and finding out what's known can actually be quite helpful for you. And then, so then finally, just to realize that the doctors and nurses will know more about, sort of specifics about management, about certain things to do, but they may not be familiar at all with these disorders. So having that education, having your report in hand, having some of these materials that GFPD's created can really help. So that's my advice. I think, so then the other part of this where we were going to open this up for discussion or questions.
Do you have any questions?
Yes.
Sorry. I just want to also add while I'm walking, the treatment guidelines are on our website. So under Scout, is that your question? So the treatment guidelines are on the website, the scholarly article area, and there's quite a few articles that you can find there. We also send to all families, so you can always message me, Katie@GFPD.org, and I will be happy to send those to you. We send to every new family the symptom prevalence publication as well as the treatment guidelines, and we strongly recommend within the email to please take this, send this, whichever way, get it in the hands of providers that are caring for your children.
I do have a question. My son is 30. Do these guidelines still help his physicians?
Yes. So, you know, we sort of discussed over time and, you know, depending on severity within the guidelines. And then, you know, the other aspect is to sort of remember that, you know, particularly adult doctors may be very, so that issue of like, that they would look up Zellweger syndrome and see sort of, well, this is going to impact infants. An adult doctor may be very confused by that information. So it may require like sharing the guidelines and then actually talking them through. Well, no, it's a spectrum. And there are actually many adults, you know, with this condition.
And I just want to reiterate that, you know, take more than one copy. Do not just give one to the doctor. We attend St. Louis Children's Hospital, which is a partnership with WashU, and so usually, you know, see a student or a fellow before the doctor, which is great. I make sure they have a copy too, because they're going to be the future doctors. So, you know, take multiple copies. Are you interested in learning more about my child's disorder? Here's a copy. So don't just take one and think it's just for the doctor. Take a multiple. Take a stack. Any other questions?
So my question is, biochemical markers, do they always line up with the actual symptoms and effects that the child is showing?
So,
because I've read a lot of contradicting things where, you know, this child has super high markers, you know, everything's elevated, but symptoms and everything else, you know, they're not showing a whole lot, and vice versa, where the chemical markers are fairly high, but they're clearly severely, you know, affected in one way or another.
this is a great question. And I went over that quickly, leaving out some of the subtleties. So if you are, so one thing is that we used to do more actually skin biopsy and measuring how the enzyme worked. And that correlated like pretty well. But the plasma, like for instance, a plasma very long chain fatty acid is, there's a lot that can go into that level. To give you one example, in XALD, the level actually doesn't matter at all. Like kids can have pretty low levels and they end up with the cerebral form. But in ZSD, there does seem to be a better like curve if you line up and sort of, there does seem to be a better curve. Like I think that if we were trying to think about like a very young patient and we're trying to think about, you know, where are they on the spectrum, a lot will go into it. Mutations actually could be helpful. Then if we're not familiar with their mutations, maybe they're unique mutations we've never seen before, then we might say, well, what are the levels? And then we would look at what has happened so far clinically. Great question. How many of you are like from sort of newly diagnosed families? Like I guess defined as like this is your first GFPD meeting, that's great. Okay. Well.
Yeah, please raise your hands if you have any questions. Don't be shy. I feel like we're fantastic at working and talking with our families. And
I try.
yes. Thank you so much.
Dr. Wangler, real quick, thank you for being here. I know I've seen you in clinic in Houston. We had our bile acids tested, very long chain fatty acids, maybe 2 years ago now. How often should we do those blood draws to get updated information?
Yeah, I mean, it would depend on whether there's other indicators of liver issues, and then also there's I think in your case we were looking at sort of the bile acids by FAD, right? Like a very accurate send out test for bile acids. But I think for a patient where there's not a lot of those liver enzyme elevations and there's not a lot of concerns about the liver, it might not be done regularly at all. But I think definitely doing a baseline and then if there are some elevations, I think we're probably often measuring like every couple years. We're not going to be doing it every year, but probably every couple years. But then I will say that so if there's a discussion of using one of like the therapies, like the folic acid therapy, then it's going to be done like in that context, right? Which would be much more regular. So I guess my answer was more about screening, but in therapy you're going to be doing it more regularly.
So you probably kind of answered the question from what she asked too. Would there be a reason why your provider has not done the fatty chain acid testing at all? Like my son was diagnosed through DNA sequencing, and they have never done that test on him.
Yeah.
They mentioned it, but it has never been performed on him. So I have no idea where his markers are at
Sure.
all whatsoever. Is there a reason why they wouldn't do it?
I mean, I would do it in terms of just the very long chain, the plasma, the very long chain fatty acid. I think there's plenty of evidence to say, do it. If the mutations that you have are like well established and the symptoms are all lining up, could someone argue like, well, you're not learning anything from this test? I still think, it'd be nice to know, are we low levels, high levels? I still think that would be nice to know. So I think for the plasma very long chain fatty acids, I would do it. But we used to do many more things that I think would not be recommended in that scenario. Like we used to do skin biopsy and enzymatic assay. I don't think you really need that if you have mutations and we know what the mutations are. I don't think you need those measurements anymore.
I'm going to jump in again. You just used the word that I just want to make sure that everyone knows we do have a lot of families, a lot of new terminology, and the variants of the mutations in that language. And if you hear those words, know that they mean the same thing. There's just a terminology change, so don't feel like I know what that means. So whether we're saying mutations and we're saying variants, same thing.
A very futuristic question. Has anybody started like a genetic reconstruction to maybe try to rebuild a person's DNA or genes?
Yeah, good question. Because obviously you read about things like CRISPR in the newspaper where we're editing genes, right? So you'll hear this afternoon a discussion of gene therapy. So that would be where we're making an artificial piece of DNA that contains the gene that you're kind of missing, and we're trying to replace it in retinal cells. So the problems there are you're only going to cure the cells that you deliver that to, right? And it's not trivial to deliver to like your whole body, for instance. Yesterday, we also heard about a different technology where you use a small piece of nucleotide like DNA or RNA to maybe suppress a certain gene, which for a lot of the kids that may not be helpful, but like in some situations there's something abnormal going on with the gene that if we calm that down. So those are all things that are being thought about. The limitations are, again, you have an individual who has billions of cells or trillions of cells, and you have to deliver. You're only going to address the cells that you deliver. So that's one of the major limitations. And then how long that product will stay.
One more question.
Dr. Wangler, I have a question about the very long chain fatty acids. I don't think we've had that tested in a while, probably since we've seen you. And I feel like right now we're using but it's our fault, we did it. Using the liver elastography, if I'm saying that right, is more of kind of monitoring progression. But do you feel like the very long chain fatty acid does give you an idea of progression of the disease?
No, I mean, in your situation, I think that situation to me is a bit different. I mean, because we sort of know the level that you were at, and we sort of know, like, in yours. Sorry, I'm not going to give away your secret. I'm supposed to keep it private, I guess, or something. I don't know. But anyway, in your situation, we sort of know the mutations, so there's not a lot of mystery. We would expect from the studies that as a person ages, the very long chain fatty acids in plasma actually go down over time. But that doesn't. The one mystery is that, like, you could look at adults with the condition. You could look at their plasma and sort of say, wow, pretty mild changes, but the severity is more, they could actually be intermediate or mild or, so the severity doesn't correlate with that. It's not like they get better, it's just that the plasma seems to clear that excess over with age.
Thank you.
Could you talk a bit about the different PEX mutations and how that kind of affects what you see in your child? My son has a more rare one, and I'm just curious if that plays a big part in how we see it.
Yeah, great question. And I didn't put in a slide of sort of all the mutations. So like the most common gene that would be involved is going to be PEX1, and then that's sort of followed by sort of PEX6 would be sort of second, and but of course we're aware of patients with sort of where all the PEX genes we're aware of at least a handful of cases. So the idea is that basically each it shouldn't matter that much which PEX gene. It matters more like the strength of a mutation. So if someone has very mild PEX1, they probably will have mild or mild intermediate clinical manifestations. If someone has very damaging mutations in PEX6, they'll probably be on the severe end of the spectrum. But I will say that there are a few atypical cases that seem to be where the symptoms don't quite match with some of the other patients that we've seen. One example is there's kind of a cerebellar ataxia phenomenon that we've seen in some patients around the world. That seems to be like specific genes like PEX16 and PEX10. So it's a great question. I think you can consider knowledge about the specific mutations as probably a little bit more important than which PEX gene. But the only issue is that, of course, you have fewer families to interact with that have your specific situation. And that, that is sort of, I've seen that in other rare diseases. You sort of have maybe a couple common mutations, and there's a lot of families in that group. And then there's people that just have their own private mutations. So you're not alone even in that situation.